you. Now, I would like to apologize to my fellow hosts and actually Dr. Mawela, Dr. Machete. I've changed the topic, but the content is the same. It's quite a broad topic that, I had to present, but hopefully I will capture all the essential things around this matter. So this, that will follow, it's exactly what breast cancer means to the gynecologist. And I'd like to declare that there's no conflict of interest that I have to declare. Now, this, when I was preparing the talk, I actually thought back, I'm like, I've had quite some experience coming across breast cancer in my short career as a medical doctor. And maybe before that, with my recent training, I actually realized that Dr. Machete and colleagues have taken the breast away from us.
True. It used to belong to the gynecologist.
Exactly. And we were sleeping just laparoscopy. The surgeons took it over from us. But it's always nice, to learn a thing or two from you guys. I think you've really mastered the breast. And based on what I'm going to tell you now, I think I'm comfortable, being limited to below the knee. I mean, below the belt and above the knee, which is what
Sure.
right sort of depicting. So I'm very happy with that. Now, my first memory was when I was in fourth year, sitting in an OSCE, one of the end of block exams, and having examined a patient with breast cancer, and I had to tell Prof. Mudiba, who was the head of general surgery back then at Medunza, my clinical findings, which made me convinced that this patient has breast cancer. I remember the retracted nipple, the bloody discharge, the pure orange, which I had to look up a lot in the medical dictionary. And so, yeah, those were like a very uncomfortable experience when it comes to breast cancer for me in the fourth year. And I thought that was it until I went to the part 2 exam for Obs and Gynae. And one of the OSPE questions, so this is basically a case that you get given and you need to prepare. And lo and behold, it was a patient who had breast cancer in pregnancy. So you can imagine how I felt. I started, sweating. I had to loosen my shirt a bit, start thinking, because I had 15 minutes to prepare before the questions would come. So yeah, that was my encounter, and it actually never ended there. So I think it's really following me. Maybe I must really try and fight the war and take the breast back for my colleagues from the surgeons, because in my first year of private practice, I actually had a young lady, a 21-year-old, who came to me as a primigravida. I started seeing her early in the first trimester. Now this lady, outside, everything else, pregnancy was basically a low-risk pregnancy. But she did give a history that she had a fibroadenoma that was diagnosed about 2 years before she fell pregnant. So we basically followed her up, examined the breast, but as the pregnancy advanced, the left breast became bigger and bigger until, it looked like there was an abscess in there. Subsequently seen by a surgeon, biopsy and drainage of that abscess was done. And unfortunately, it came back as a malignancy. So she had a phyllodes tumor of the left breast, and she then subsequently had a mastectomy done during the pregnancy. She did, however, carry the pregnancy to term, delivered well. Currently, she's doing very well. I've seen her post-delivery, and she's doing very well. So my journey with breast cancer never ends until a couple of weeks back when Dr. Mawela made me very uncomfortable again to say, hey, doc, please come and talk about this topic that you're so uncomfortable with. So here I am now delivering this talk to you guys. But I must say I've enjoyed preparing the talk, and yeah, I'm still looking forward to it. Now, reproductive health, there's a statement from the WHO. Basically, reproductive health is not necessarily the absence of reproductive disease. It all has to do with, how the woman is psychologically, sexually, and whether or not she's able to reproduce and have her own kids. And this cannot be more true for patients who are having or diagnosed with breast cancer, as my previous speakers have said, that unfortunately, currently, we see a lot of these young women And I mean, a case in index, my patient who's 22, who was now diagnosed with a breast malignancy. So it's very important to not forget the reproductive side of all people, patients that we see with breast cancer. Coming to issues of contraception now, I'm actually going back to the original topic. Contraception, I actually wonder if I've not opened or not the correct PowerPoint or presentation. Contraception, so generally all forms of contraception except the non-hormonal are recommended for patients with breast cancer. As one can imagine, I mean, the previous speakers have mentioned the receptor susceptibility or the presence of receptors for estrogen and progesterone. And this is basically the basis of all our forms or most of our contraceptives. They either contain an estradiol with some kind of a progestin, or it's a progestin by itself. And then we always worry that if we actually give these women this type of hormonal contraceptive, either they will accelerate the progress of the disease or they might cause recurrence. So all of them are basically MEC3, as you can see. So the WHO has got the medical eligibility criteria, which basically tells us and guides as to what type of contraceptive can be used for that patient you're seeing in front of you. And the only one that is MEC1. So MEC1 basically means you can use without limitations. And I mean, for probably everyone, abstinence would be a MEC1, if not MEC0, because it's definitely safe and can be used by anyone. But failure of abstinence, then the next best thing would be a copper intrauterine device, which can be used without any limitations. But everything else, then it's basically MEC3. Which basically means that the risk associated with that type of a contraceptive is quite significant. But if there's no other option, you may use it. And MEC4, it's absolutely no contraindicated for use. So all of the hormonal contraceptive methods are actually MEC3. So this can actually be accessed through the CDC or the WHO website. There's also an app, maybe, for colleagues who are interested in having access to this app. There's an app that you can download and you can put the profile of your patient and it will advise which contraceptive is safe for your patient. Going back to the issue of fertility, I mean, it's Dr. Manyachi just said a mouthful on it, that there's a lot of psychological issues around breast cancer and what follows thereafter. In most cases, the moment the diagnosis is made, the focus is about getting better and being cured from this cancer. And some women, for instance, like this particular woman where it says time 3 in this qualitative study by Cornell S., she actually never thought about the issue of reproduction until she was probably cured, and actually now started thinking that, oops, now I have to consider having my own family. And it's a topic that can never be ignored. And each time we make a diagnosis of breast cancer, we have to go into issues of reproduction with these patients. Now, what are the issues with regards to fertility and breast cancer? We worry a lot about the adjuvant therapy that is being used. The mastectomy itself, if it's done, it doesn't really interfere with anything, but the drugs and the radiation that may be used, it's the one that concerns us. So particularly if chemotherapy is used, we do know that it may impair follicular development during that time when the patient is on the chemo and perhaps a year to 2 thereafter. It may also be cytotoxic depending on what is used. You may also have cytotoxicity to the actual oocytes. So obviously that would actually negatively impact fertility. Now, with regards to how do we then assess fertility? So this woman has been treated for breast cancer and she would like to conceive. How do we then assess? Unfortunately, there's no guidelines. We do know that when we manage patients with infertility, there's them, if the woman is less than 35, it's a year of adequate sexual exposure without any form of contraception at the right time and she doesn't conceive. Or if she's more than 35, then it's only 6 months. But with these patients, we don't know. when do we start worrying and what tests do we do? So the only recommended test currently is the anti-Mullerian hormone, which basically is the only marker of ovarian reserve. And I must say that for patients treated for breast cancer without oophorectomy or bilateral salpingo-oophorectomy being done, they often actually resume their ovulatory cycles, even though it may not be in the first 2 years after treatment, but they do, and they actually do conceive spontaneously without, any kind of intervention. And in terms of when must they actually start trying for a pregnancy, so the time frame that's recommended, it's about 2 years. So she gets treated, followed up, because the first 2 years are basically it's that period where they are likely to recur. So you wouldn't want them to recur during a pregnancy. And it's very important if other therapies such as your selective estrogen receptor modulators, the Tamoxifen, if it was used, for the patient to be off it for at least 3 months because of the long half-life and the fact that it can be teratogenic, to the baby when they do conceive. Now, what are the options to preserve fertility? So now there's a big move. It's actually called fertility. So basically what I said in the previous slide, to say when a woman is diagnosed with cancer, the first thing we need to ask ourselves is, how do we preserve her fertility before we actually treat the cancer that they have? Because whatever cancer the patient may have, whether it's bowel, lung, thyroid, or whatever, whatever treatment that is used is most likely going to impact on the ovarian reserve. So you always want to try and protect that, because it's the only way that they can possibly fall pregnant. So there's different options that have been explored. For instance, the gonadotropin releasing hormone analogs. So so these are the ones that would basically shut down, the gonadotropins that basically go from the pituitary down to the ovaries, the FSH and LH, and therefore prevent the ovary from having development of follicles or oocyte maturing so that they can be ovulated. This is still under investigation. We need more evidence that will actually support its use. But if one, was to consider a more conservative option, this perhaps would be that. And then the other option that is out there, and, it's widely practiced, even though the uptake of it is very limited, perhaps due to the cost, which is associated with these options, are cryopreservation. Now, cryopreservation basically means that the woman gets hormones to stimulate her ovaries so that many eggs actually mature, and then those are actually taken and stored, freezed and stored, so that once she's completed a treatment, she can actually undergo IVF and then fall pregnant using her own eggs. And the other one, which, it's not widely practiced, it's embryo freezing. So they basically stimulate the ovaries, get the eggs out from the ovaries, do the process of in vitro fertilization at the lab. Once all of those embryos have been formed, they are then stored and for later use. Now, the last one is ovarian tissue cryopreservation. So instead of stimulating the ovaries and doing all of that, it's they basically just take tissue from the ovary, which can be implanted at a later stage. Again, this is only recommended at this point for research purposes and not for wide practice. And just to mention, with regards to the cryopreservation for oocyte and embryos, there's always a concern, obviously, during the stimulation period. There's it's actually a stage or a phase where there's very high estrogen circulating, and one gets concerned if we have an estrogen receptor positive tumor as to the progress of the disease during that time. And also the delay in initiating treatment, because this could take about 2 to 4 weeks before the treatment can actually be started for the cancer. And now just looking at outcomes, because obviously this has been investigated and evidence is coming out as to how these women do once they've tried to preserve their fertility. So this is probably the biggest cohort study. It's a French study. They had almost 16,000 women. And I must say, if you look at where it says results, there's the uptake for oocyte retrieval and cryopreservation was very, very poor until 2019, where they again still reached about 17%. In 2019, it was a 10-year duration study, and of all of these women that actually opted to preserve their gametes, only 5.6% of them actually went back for the IVF process. And in this particular cohort study, they noted that even the ones that went back, the pregnancies were not associated with the assisted reproductive techniques. It was actually spontaneous conceptions, and there was probably not very much benefit of them having stored their eggs. Probably this is because, if they use chemo, it's a temporary issue during that period, but years later, they actually resume, their normal ovulatory cycles. So oncofertility, again, as a conclusion in this study, it's emphasized that it's important, and the uptake is unfortunately very poor. And I mean, France is quite an advanced country. You can imagine in our setting here that probably very few of the women who have breast cancer have access to this type of a service where they can store their gametes for future use. Now, coming to the uncomfortable case I came across at my exams, it's breast cancer and pregnancy. And I think this is where I actually start calling my general surgery colleague to come and help, because now I don't know what to do. So basically, it's a multidisciplinary thing. Of course, the general surgeon is very key because they are primarily the ones that will manage this patient. I'll look after the pregnancy, which makes life very easy for me. So yes, and psychological interventions, and social, and etc. So the key issues, it's basically, what do we do when we diagnose the patient with breast cancer and pregnancy? What outcomes are we sort of looking at for the cancer, as well as for the pregnancy, and the prognosis, and what happens post-delivery? Now, coming to the management, as I said, you call everyone, because you can never manage a patient alone, and this applies, even to your patients that come with flu. You must always try to never, fully manage a patient by yourself. It's always good to have someone else have an opinion and a hand in terms of managing the patient. So there's always issues around the use of chemotherapy because of the pregnancy changes, the pharmacokinetics and pharmacodynamic changes that one experiences in pregnancy. It's possible that, the clearance, the renal clearance of the chemo may be higher, and therefore the efficacy may be lower, or you may even have that spacing of the chemo, in the amniotic space, and you may actually have toxicity from that because you think that the levels are low in the blood, only to find that there's actually a lot in the amniotic fluid, which serves as a reservoir and a constant supply of the chemo. And I must say that at this point, if a woman is diagnosed with breast cancer, the studies have not shown in terms of survival benefit or any oncological outcomes when it comes to termination of the pregnancy. So TOP is not indicated, except if, say, you've counseled the patient and they just opt for a TOP, then absolutely. Or you are pushed, to give radiation for whatever reason, then because the radiation is contraindicated in pregnancy. For those two reasons only can we offer her a TOP. Otherwise, we manage the pregnancy and deliver at term or sooner if there's another obstetric indication to do so, or an indication for treatment of the breast cancer. Now, in terms of what we then do, or probably Dr. Machete would actually have more input when it comes to this. In the first trimester, we don't give chemo because this is when, teratogenic effects are the maximal. This is there's organogenesis. We don't want to expose, chemo, because chemo, remember, it destroys rapidly dividing cells. So you are most likely going to end up with problems if you give chemo during this stage. But of course, surgery, be it a radical mastectomy or lumpectomy, and I think it will be at the discretion of the operating doctor. But in the second and the third trimester, you can offer surgery as well as adjuvant chemotherapy. It's been shown that it's safe, and organogenesis is already complete by this time. So adjuvant can actually be used in the form of chemotherapy. We do not use tamoxifen though during pregnancy, just to mention that. And with regards to obstetrics, so we do the easy stuff, and the easy stuff for me is to basically check that the baby is doing well every 4 weeks, just to look at the growth of the baby, look at the Dopplers, you know, if I'm concerned about growth restriction. And of course, the anatomy scan is very key in the second trimester to make sure that there's no congenital anomalies that can be picked up, and, you know, the fetal echo to look at the heart, that all is well there. And then, of course, if there's a suspicion of for growth restriction, then one may need to do more ultrasonographic assessments, which will guide the decision for further management of that pregnancy. And then again, this would not end up at the level of a general gynae like myself. One would have to involve the maternal and fetal medicine subspecialists who are actually skilled, you know, to look at the anatomy of the baby during this time, and also guide further management of the patient. In terms of pregnancy outcomes, miscarriages, there's a high risk of miscarriage, particularly if we start treating the cancer in the first trimester. That's why even the surgery itself, it's advised that you at least get to 12 weeks and then do whatever kind of surgery that is planned. There is a risk of antepartum hemorrhage, so abruptio placenta particularly, and the risk of fetal growth restriction. And looking at prognosis, because, you know, the woman would now worry, what happens to me if I continue with this pregnancy and I've got the cancer? Am I not putting my life at a risk? Why should I not just terminate the pregnancy and get treatment? And actually, there is some truth to that. All along, you know, many studies had said the prognosis is similar to those that actually get breast cancer outside pregnancy. Unfortunately, you know, the data is actually sort of changing. So this is a meta-analysis from 2020 by Shao et al., where you can see, Dr. Moyle, I hope if you can assist me, I'm trying to get the cursor, if Dr. Machete can also assist, so that I can sort of guide, because the next few things that, it would be good for me to be able to point. Otherwise, the slides get so busy.
Sure. No, you can exit full screen. Then you can show with your mouse cursor. It's okay for those particular slides.
Out and in. So, okay, no.
Yeah, you use escape. Yeah, like that. Yes.
Thank you. Thank you. That's one thing I still have to master.
Slide 15. Yes.
So we. Okay. All right. So you can, these are all the studies, and, you know, their weight in terms of how much they contributed to the meta-analysis. But what I think is key for us to look at, you know, is this risk ratio of 1.45. So this is the risk of death if a woman falls pregnant. You want it to be less than 1. So if it's above 1, it just already tells you that, you know, the risk of mortality in patients diagnosed with breast cancer is actually high. Of course, the heterogeneity is a bit high here. It's 64. You want it to be less than 50. It just tells you that the findings from the studies themselves sort of, you know, vary widely, and some few that have got very wide confidence intervals. But nonetheless, the overall assessment, you know, it does confirm that the risk is actually higher if they do fall pregnant and in pregnancy. I mean, and they have breast cancer in pregnancy. Okay, now coming to post-delivery, what then happens? Breastfeeding is not contraindicated. However, it may be a challenge for them to breastfeed, particularly if they've, you know, had some kind of breast surgery, either a lumpectomy. Of course, if they've done a mastectomy, the contralateral breast can still breastfeed. My patient actually breastfed, and she did quite well. But if, say, lumpectomy is done, pregnancy is not contraindicated. I mean, breastfeeding is not contraindicated. but it may be a challenge because of the scar tissue and, you know, the technical challenges with the actual breastfeeding itself. And if they are receiving adjuvant chemotherapy, then we would basically advise, you know, against breastfeeding, because obviously most of them are actually excreted through the breast milk. There is a few that, you know, she can breastfeed if she really wants to, and she's on chemo, but generally would have advice against breastfeeding. And then coming to breast and gynecological cancers. So the BRCA genes, these are tumor suppressor genes. So these are those, you know, genes, you know, in our chromosomes that basically would identify the cells which are now, you know, misbehaving and having some abnormalities, which are likely to lead to cancer. And, you know, they sort of destine them for death or no further progress in terms of their division. Now, if one has mutations, particularly in the BRCA1, call them BRCA genes, BRCA1 and BRCA2, it actually puts them at a very high risk of developing breast as well as ovarian cancer, the two combined. And the history would be very, very suggestive of it if one goes through a detailed history of the family. So this is one that really concerns us, and these are classified as high-risk women, and their interventions for prevention as well as treatment is different from the general population who is at the risk of developing breast or ovarian cancer. Now, there's management guidelines, South African guidelines, and that were published in the South African Journal of Gynaecology in 2018 by Tracy, which basically guide as to how would we or should we look after women that have got BRCA gene mutations. So with regards to screening, so the screening first for BRCA mutations, there's different tools, but basically those tools, they try and identify the risk factors such as having first-degree relatives with breast cancer, young women less than 40 in the family being diagnosed with breast cancer, having breast cancer in a male family member, and of course, if they are from the Ashkenazi Jewish lineage, they're at a very high risk of having BRCA mutations, and those are the ones that would actually undergo genetic testing to confirm whether or not they are BRCA gene mutation positive. And with regards to surveillance now, so say we've done the test and we've confirmed that they are positive for the BRCA gene mutations. With regards to the breast, there's different recommendations, but according to this, you know, guideline, they recommend that, you know, a young woman from the age of 18 must start, you know, self-breast examination. We know there's issues around that. Whether, you know, she will do it the right way, we should not be concerned, you know, about small lumps that generally are not an issue. But up until the age of 25, then the recommendation from this guideline is that they must have annual MRIs. The other guidelines would actually say you must do annual mammography, but there's of course a concern with prolonged exposure to radiation, which some studies have shown that it's actually of no harm. There's no increased risk of breast cancer with those annual exposure to radiation. So this particular guideline says MRI between 25 to 29 years. Thereafter, you can consider doing a mammography. That's with regards to breast. And with regards to ovary, unfortunately, there's no way we can, you know, even in the general population, prevent or screen early enough for ovarian cancer, because we often diagnose it in advanced stage 3. You know, because of the challenges. But the little that we can do and recommended by this guideline is that we can actually do CA-125. So this can be done twice a year or once a year, as well as a transvaginal ultrasound to assess, you know, if there's any cysts or any masses that are developing on the in the ovaries. So that's as much as, you know, it goes with regards to surveillance. And coming to chemoprophylaxis, I think Dr. Machete touched on it a bit. When it comes to breast, you know, there is that option of using Tamoxifen, you know, as chemoprophylaxis for those that are at high risk, such as these women. And then for ovary, the use of combined hormonal contraceptives, we know that they are quite protective. They are excellent in terms of preventing cancer of the ovaries. and many other benefits that women love a lot, you know, when it comes to skin and menstrual cycles and heavy flows and ovarian cysts, etc., etc. So if one has this type of a woman, they would actually benefit from getting a combined hormonal contraceptive, be it in the way of a patch or, you know, combined oral. It does actually help to prevent ovarian cancer for the BRCA positive women. And then when it comes to risk reducing or risk reduction surgery, I think one, you know, if you follow in the celebrities, Dr. Manuela mentioned the celebrities requesting mastectomies earlier. We know Angelina Jolie, apparently she was diagnosed as having one of these mutations and she went for a mastectomy. So absolutely for such women, there is that option of them having a prophylactic mastectomy even before they develop the cancer. It's been shown to reduce mortality from breast cancer. And coming to the risk with regards to the ovary, bilateral salpingo-oophorectomy is recommended, and it's been shown that it does reduce mortality from ovarian cancer as well as breast cancer if done in this population of patients. But however, you know, the moment you remove a woman's ovaries, generally whatever the indication is, the life expectancy, you know, gets shorter, and of course everything else that happens to a woman in menopause, you know, comes immediately during that time. Whether it's psychological issues with their skin, the genitourinary syndrome of menopause, osteoporosis, sexual dysfunction, etc., that follows immediately. So the current recommendation from this guideline is that that can be performed for women that have completed their family after the age of 35. And then there's a new concept now of opportunistic salpingectomy. So this is probably not what, you know, the naughty people in the group are thinking, the BS. It's basically bilateral salpingectomy. So it's been shown recently that ovarian cancer actually originates from the fimbria in the fallopian tubes. So if we remove the fallopian tubes, we actually reduce the risk of them developing ovarian cancer. It's still under investigation, and in this population of patients, it's not one that one would actually recommend. And then what happens? Say this young woman has had a bilateral salpingo-oophorectomy for risk reduction. We have to put them on hormones, because if we don't, everything else that I mentioned that follows after menopause then comes. But then again, we know the issues with hormonal replacement therapy with big studies, you know, the Women's Health Initiative studies and many other studies that have actually found an increased risk of HRT, depending on whether you use progesterone with estrogen or estrogen by itself. But the findings, we do know that they support, you know, the use of estrogen only, and that it does lower the risk of ovarian cancer or even breast cancer for that matter. So it can be used. So we should not deny them access to hormones, you know, after we've removed their ovaries, because of the fear that, I mean, we remove the ovaries because they produce estrogen, but then we give them estrogen. It doesn't make sense, but scientifically, it actually helps, you know, in terms of preventing the cancer, and it does not increase the risk of them developing a recurrence or the cancer itself. Now this is where me and Dr. Machete give each other a call in the wards. We've had some of this, you know, during my time there at Rob Ferreira, where not necessarily from Dr. Machete, but of course from the team where we, and maybe as a registrar as well, I've had a few where, you know, the other colleagues would call and say, hey, doc, we've got this patient, young patient, she's got ovarian cancer. Could you please consider doing something about the ovaries, whether it's, you know, an oophorectomy, because we are treating her, we don't want the cancer to progress or to recur. What then do we do? Or, you know, this patient is on tamoxifen, we've done a scan, the endometrium is thickened. Please help to assess, you know, the endometrium. And just to maybe briefly discuss that, we do know that ovarian suppression, there's robust evidence to say it actually improves the oncological outcomes. So the disease-free survival as well as the overall survival is improved with the ovarian suppression. So ovarian suppression in short, or by definition, is we don't want the ovary to be active. So we need to shut down its ability to produce estrogen or hormones. And options for that, we can use drugs like the gonadotropin releasing hormone analogs, which basically would shut down the FSH and LH, and therefore you won't have folliculogenesis, and therefore if you don't have that, you won't have the estrogen as well as the progesterone that gets produced from the ovaries. And then, or you operate on them, so you basically remove them or ablate them, and some use that term, or you radiate, to say you don't want them to be active at all. So those are the options. The issue always is, the menopausal effects, which makes many of us, not comfortable to do it for the colleagues. And I mean, it's a legitimate, as I said, request, because we do know that it improves the overall survival as well as the disease-free survival. But because of the issue that follows, after these have been removed, we often shy away from doing something about the ovaries. Yeah. So with regards to the issue of endometrial cancer, and by the way, maybe I should have said when I put on that other slide on a patient on tamoxifen. Now, tamoxifen is a selective estrogen receptor modulator. In the breast, it would basically block the estrogen receptors, but in the endometrium, it actually stimulates them. So you get hypertrophy of the endometrium, and we know that if the endometrium hypertrophies, you get hyperplasia, which then starts as, with no atypia. Eventually, you get complex with atypia or simple hyperplasia with atypia, which is like a pre-malignant lesion to endometrial cancer. So there's always that concern that a patient on tamoxifen, they are at a very high risk of developing endometrial cancer. So especially with prolonged use, more than 5 years and up to 10 years, it's been shown that, the risk of endometrial cancer is actually increased about 2 to 7-fold with the use of tamoxifen. So again, this is a very legitimate request to say, please look at it. We don't want her, being cured for the breast, but now she develops endometrial cancer. Please look at her and have a look. Now, this is just to support, how effective tamoxifen is with regards to treatment of breast cancer. Now, with regards to local recurrences, again, a forest plot like the other one we just saw. So this is exactly where we are. It actually is very good in terms of preventing recurrence. Yes, the heterogeneity is a bit high there. And in terms of disease-free, disease-specific mortality, it is less than 1. Again, the longer you use it, more than 10 years, the better it does for you. But then the issue is that endometrium that we were talking about. And then again, I mean, you just have a look there, way less than 1. So it's a drug which is very important for the breast, but the concern is the endometrium. And you can see on this one, on this plot again, with very good heterogeneity there, and you can see the risk of mortality from endometrial cancer. It's about, what is it here? The risk ratio is 2.29. So it's significantly increased with the use of tamoxifen. But the issue now is, should we then do hysteroscopies for all these women, or should we do transvaginal scans, for all of them all the time? Should we do endometrial biopsies for all of them? Now, this is where the challenge is, because for us to be able to detect one endometrial cancer which is associated with tamoxifen, one would have to do 332 vaginal sonars, as well as 56 endometrial biopsies for one to pick one. So financially, perhaps it doesn't make sense. Yes, we always say the risk is so low, but for the one that gets the condition, the risk for them is 100%. But if you're looking at a health system like we have here in South Africa, we've just discussed the challenges that we have with regards to screening, with imaging. So you can imagine if we have to, do this for all of them, we will basically clog the system. So the recommendations from many guidelines is that, in asymptomatic women, there is really no need for us to be doing transvaginal sonars. There's no need for us to be doing biopsies. The only time that we will be concerned is if she develops symptoms such as, postmenopausal bleeding or some, offensive discharge, which is not going away. We do a sauna and the endometrium is thickened. Only then must we actually biopsy the endometrium. So again, in most cases, when there is a request for this and the patient is asymptomatic and this was an incidental finding, in most cases, the gynae would say no, but maybe let's wait for the patient to develop symptoms, which sometimes, feels unfair on the patient, because now there's something that potentially could be a problem, but we opt to not do anything about. Yeah, but in summary, the recommendation is that there's probably no clear evidence of benefit for endometrial surveillance for patients who are on tamoxifen, even though they are on it for over 10 years, and we know the risk is even higher the longer they use it. So in conclusion, as I've mentioned, one can never manage a patient by themselves. You can never, even if it's a headache, a simple headache that you think, just needs Panado. It could be a brain tumor, it could be meningitis, it could be anything. It could be a stress, it could be a psychological problem, it could be anything. So we always, involve other colleagues in terms of the management of patients. So we should never be too shy to refer. Oncofertility, it's not a new thing, but perhaps a bit of a new thing for us in South Africa, but it's something that we should offer all our women as we manage and diagnose their malignancies, whatever cancer that they may have. Even if it's a gynae cancer, there's always an option to just preserve those ovaries, preserve those eggs, preserve those embryos before we offer the patient any kind of other treatment, so that she has an opportunity to conceive in future. And then the last point there is, for those BRCA mutation positive patients, to say not all of them are actually just low risk for breast as well as ovarian cancer. We should be able to have a high index of suspicion for patients that have a very strong family history of breast cancer, breast cancer early on, in their life, early young patients with ovarian cancer. We should have a high index of suspicion and do a thorough examination and clinical assessment and refer them for genetic testing if needed, and discuss all the other options that are available to them. Otherwise, colleagues, thank you so much. It was a good journey. I enjoyed giving you guys this talk, and I'm open to any other questions that may be there. Thank you.